Hi, and welcome everyone to our program today called Advances in GVHD and Clinical Trials. My name is Stephanie Trong. If we haven't met before, I'm a blood cancer survivor myself, and I started the patient story really out of my own experience of feeling so alone and wanting to know after diagnosis, what does this mean and how can I get through this together with other people? And as we know, a diagnosis is just the beginning of figuring things out. And that's why our goal here at the Patient Story is to help patients and care partners navigate life after a cancer diagnosis. We're doing this primarily through in-depth conversations with patients, care partners, and top cancer specialists like the ones you'll hear from today. We are so proud to be partnering with the Leukemia and Lymphoma Society for this program. The Leukemia and Lymphoma Society, or the LLS, is the largest nonprofit dedicated to creating a world without blood cancers, and for decades has invested almost $2 billion in groundbreaking research and pioneering so many approaches. But on top of that, also supporting patients and families with things like the Clinical Trial Support Center, which is free one-on-one support with nurse navigators. And we'll learn more about the CTSC today. A quick reminder that this is not meant to be a substitute for medical advice, although we do hope you walk away feeling like you have more to ask of your own medical team. And lastly, we want your feedback on whether this program is helpful and what you want to know more about. So please fill out our survey that will come to you when this program ends. It'll take just a couple of minutes, and we do love hearing from each and every one of you. Okay, housekeeping is over. And now we get to the fun part, which is the conversation all about GVHD and the latest in treatments there. So I'm going to start with an introduction of our incredible panelists today. First up, Dr. Satyajit Kosuri is a hematologist oncologist with the University of Chicago Medicine. He is an expert in stem cell transplantation, leads the graft versus host disease clinic there, and also leads research to try and improve patient access to transplants. So first, Dr. Kosuri, thanks for being here, and we would love to understand what drew you to this field in medicine and specifically in GVHD.
Yeah, thank you for having me. I'm really appreciative of being able to join everyone and talk to you about this, I would say, somewhat difficult topic. It's not easy. It's not a user-friendly topic to understand or even to explain. My background, basically, when I started oncology fellowship, I was going to be a GU oncologist, and I was very much set in regards to that. And when I had done my transplant rotation so many years ago, the thing that really drew me to that was actually the fact that it spanned all fields of medicine. So you had to continue to have a pretty good breadth of knowledge. And the immunology, it was very intriguing. The fact that immunologically, we're dealing with very complex diseases, as well as the transplant itself is basically an immune system transplant when we think about it in essence. And so that really drew me into it. And, when I tell patients and their family members and fellows and trainees about the field of transplant, I usually tell them, number one, I'm an immunologist. Number two, I become an infectious disease doctor. And then number three, oncology comes in there as part of the triad. So that's what drew me to the field. That's what I find very interesting in graft versus host disease as part of the entire picture that we're trying to improve upon within the context of transplant.
All right, next up, we have Dr. Shanann Holton, who's a hematologist oncologist with Roswell Park Comprehensive Cancer Center in upstate New York in Buffalo. She's the chief of blood and marrow transplantation, has led so many clinical trials in GVHD, and her research has led to the discovery of things like the AREG biomarker for monitoring graft versus host disease. So Dr. Holton, what drew you to medicine and specifically this focus on graft versus host disease?
Thank you also for the opportunity to be here. My story is a lot like Dr. Kosuri's. So in medical school, I was most interested in rheumatology, infectious disease, cancer medicine, critical care medicine, dermatology, and plastic surgery. I thought, how am I ever going to pick between these different specialties? I like them all. And plastics, I loved cancer reconstruction and that connection with patients going through cancer and giving them hope after a devastating diagnosis. So on a whim, I took a rotation on the BMT service in part because it just sounded cool. The other part of it, I didn't have to work weekends. And as a very tired fourth-year med student, I was excited about that. But I was stunned to see that it was literally every great aspect of medicine to me rolled up in one specialty. So, I was sold as a med student and have never looked back.
Thank you so much. Next up, we have Ashley Giacobbe, a clinical trial nurse navigator with the Leukemia and Lymphoma Society. Ashley, we're going to get more into the work that you do, but if you are meeting someone, so some patients and some care partners, what is the elevator pitch? How do you describe the work that you do with the CTSC, the Clinical Trial Support Center?
Absolutely. So I am a nurse navigator with the Leukemia and Lymphoma Society's Clinical Trial Support Center, and we are really here to provide individualized clinical trial searches and clinical trial resources to patients with blood cancers, or potentially patients who have had blood cancer in the past, but may be managing some of the long-term effects of their disease or treatment. And so we provide one-on-one connection with patients, with caregivers, or even their healthcare providers, and we take the time to learn more about a patient's diagnosis, potentially their past treatment, or any other medical conditions that could play a role in their eligibility for clinical trials. And then most importantly, really taking the time to learn about patient and caregiver preferences and any unique obstacles that may hinder or support their participation in a clinical trial, so that we can target the support that we're able to offer and really give those personalized resources.
We also have Meredith Cowden, who is a chronic GVHD patient advocate, co-founder of the GVHD Alliance, and also someone that I was able to very luckily meet this year. So can you share a little bit about, your diagnosis? I know you underwent a transplant, was it 2001? And it was acute, it was AML, right, in leukemia. Please share a little bit about what led you to the transplant and why you have decided now to dedicate your life to advocating for so many other people with GVHD.
So, like you said, I had AML, and so from what I understand, when I was 19, so this was 22 years ago, so this was a hot minute ago. The way that I understand it is that the kind of leukemia, acute myeloid leukemia that I had, required chemotherapy, just wouldn't really completely work ever, and so I needed to have a bone marrow transplant. And so it wasn't really necessarily a decision that I myself was like, yeah, let's do this. It was like, this kind of just has to happen for you. And I was like, okay, that's fair. And so then I, shortly thereafter, I developed acute graft versus host disease, and then I developed chronic graft versus host disease, which I've had since then, since April of 2002. And so I actually originally was not really into like the patient advocacy world. I just wanted it to be done. I didn't want to really deal with it. I was kind of in that particular place of like the healing process. And I think the thing that happened for me is that I got really, really frustrated. And frustration is like one of the greatest motivators for me. I got angry and I got frustrated. And then I was like, this is not okay. For me, this is not okay for anybody else.
I want to start from the very beginning. It is a very daunting, even just the term graft versus host disease, or even hearing about transplants. None of this is fun. So let's start by humanizing this a little bit. Let's define what GVHD is. And Dr. Kusuri, we'll go to you first.
When I think about what I tell patients and their family members when we're in clinic, like I mentioned, it's a very complex thing to grasp. And so I break it down as simply as I can. And I think the first concept that I describe to patients is, number one, when we're doing a stem cell transplant or bone marrow transplant, what we are, and I mentioned this before a little bit earlier, we're basically doing an immune system transplant, or what ends up being an immune system transplant. And then I talk about oftentimes, what does the immune system do for us when we're healthy? Basically, it does a lot of things, first of all, in the human body, but when we think about it simply, it's there to protect us, whether that's bad cells that it's getting rid of or protecting us from various infections. And the way that it helps to do this is it considers the body that it's growing up in as its neighborhood. And so it has this inherent desire to protect its neighborhood, and it recognizes the body that it's in as being part of itself. And when there are things that are not supposed to be there, it recognizes them too, and it gets rid of them. And so if you think about it, we're taking the stem cells or the parent cells from a very healthy person with a healthy immune system and blood system, and we're putting it into the transplant recipient. And what is happening is that this immune system is growing up inside of this new neighborhood, you can call it. And for the most part, and this is where matching comes into play, it recognizes that new neighborhood or new body as being its own, being self. And it kind of leaves it alone, and it takes up that mantle of, I'm going to protect this body, and I'm going to eradicate any leukemia cells that are there. So that's what we call the graft versus leukemia effect. But sometimes what happens is there are maybe parts of the new neighborhood that it recognizes as being not self, or not what it's used to. And so it starts to grow a little bit suspicious. And immune systems, when they grow suspicious or they recognize not self, they're programmed to do one thing, and that is to attack. And so this new immune system basically can attack the recipient from the inside. And this can lead to some sort of inflammatory physical damage to the patient or the recipient of the stem cell transplant.
Thank you. I appreciate the neighborhood analogy. It helps to picture what's going on there. But so it's this foreign something, and then the immune system attacks. And so, Dr. Holton, what are the main types of GVHD? If you could talk about how they differ and what some of those common symptoms are.
We mainly think of graft versus host disease in two phases, acute and chronic graft versus host disease, although there can be some overlap between the two. Primarily acute graft versus host disease happens within weeks to the first few months post-transplant, and that has a particular pattern. Most of the time it's a red skin rash, but sometimes can also lead to nausea, vomiting, diarrhea, and liver abnormalities that we might see on blood testing. So very clear time during which this develops and pretty clear clinical presentation, pretty easy to determine what it is. Chronic graft versus host disease typically happens later in the months to years after transplant and can be more subtle and difficult to diagnose. So just as Dr. Kosuri was saying, this is primarily an inflammatory reaction at the beginning. This inflammation ultimately will gradually lead to scar tissue. Think of a wound that is having some difficulty healing. There's a lot of inflammation, and the body tries to stop that inflammation by putting a scar on top of it. And this can happen in almost any organ in the body. And again, it can be subtle and difficult to diagnose sometimes. Usually the skin is involved, but it can also cause dry eyes, dry mouth, mouth sores, difficulty breathing, difficulty swallowing, changes with the muscle tissue, fascia, making people feel stiff and have muscle cramps. Really any organ can be involved with chronic graft versus host disease.
Got it. And it's just a follow-up there, Dr. Holton. When does it technically then turn into, from acute, you mentioned weeks or months? Is there an official time where it's okay, now we know it's chronic?
Great question. There's not an official rule on that. When Dr. Kosuri and I were in training, we were probably taught that acute graft versus host disease happens before day 100 and chronic GVHD happens after day 100, but that's not really true. The biologic processes can really happen at any time post-transplant. It's just usually the acute GVHD is in the first few weeks to months. But we have even seen acute manifestations of chronic GVHD happen much later. Chronic manifestations, even though we think about this as a later problem after transplant, we can see some of those changes even within the first few weeks. So the lines are really blurred now, and we really describe graft versus host disease based upon its symptoms and appearance rather than time frame post-transplant.
Meredith, you have your personal story with this. It is N of 1, so this is not for everybody, but what was it for you in terms of those first symptoms that were acute? And at what point did you realize this is not going away, and how could you tell?
What I noticed at the beginning with acute GVHD is that I had a couple of different things go on at the same time. So the first was that my stomach started to bother me a lot, and I got very nauseous, and it was hard to find food that I could tolerate and that was appetizing to me. So I had some of the GI stuff go on, and then also I developed a rash, and my skin got quite it really. I mean, I'm naturally kind of a pasty pink person, but it got really red and it burned, and it was hard to wear clothing. So that was kind of the beginning of the acute GVHD, and then it sort of started to transition um, from that. So I received treatment for that. That kind of started to get resolved, and then it when it moved into the more chronic manifestation, that was also really like the GI stuff just didn't really necessarily go away. It just kind of like changed a bit. And then also like my skin sort of it got a little bit different. And then I actually had a very at that time it was not really thought about a whole lot, or at least not really mentioned a lot in where I was being treated, is that I got musculoskeletal involvement. I developed a lot of it's polymyositis, and so there was a lot of pain. I was very weak. I couldn't really move around a whole lot. I lost muscle mass, and so that was, it took a hot minute, but that was one of the things that then, my doctors were like, okay, so this is GVHD. It's, because they were thinking it was something else and all this stuff. So, and then over the years, I've had a variety of different manifestations of chronic GVHD.
So I think one thing that is important that Dr. Holton and Meredith had mentioned, specifically in terms of chronic graft versus host disease, is that it can affect multiple sites in a way that may be difficult to initially pick up. And when I'm in clinic with patients prior to the transplant, one of the things that I've gotten feedback that patients have found helpful after the fact is that when we describe chronic GVHD, I tend to describe it like, imagine, and it doesn't have to happen this way, but if you imagine taking all the autoimmune diseases or conditions and rolling them up into one, and then putting them into a human body, those are ways that chronic GVHD can manifest. So whether it's the dry eyes or the skin, like a scleroderma type of presentation, or pulmonary fibrosis, it's a great mimicker. And so sometimes it can be a little bit difficult, and it can affect multiple sites. So I think that's an important point that patients can think about before they have a transplant or if they're going through it.
This actually segues into the next question, which talks about some of the severe complications that can arise from GVHD. So, I don't know if there's difficulty in noticing what the severe complications are, but Dr. Kusuri, are there any that you'd like to highlight for people today?
Yeah, so I mean, when I think about complications of graft versus host disease, there are complications of the entity itself, and then there are complications that will arise from the treatment or the way we try to treat the disease. And so what I usually say as far as GVHD in and of itself, once again, it's an immune dysregulation, right? So the immune system that's supposed to be behaving in a certain way is misbehaving, or it might be turned on and it can't really control itself. And what happens in this state, one of the major things that I think about outside of the skin rash and the other manifestations are infections are a big one. And I would say that's where we really prioritize monitoring patients who have graft versus host disease, not only from the GVHD itself, but also from the medications that we use to try to quell the inflammation and calm things down. Both of them can really lead us down the pathway of bringing down the level of protection that the human body has as it's starting trying to recover from the stem cell transplant. And so one of the things that we really emphasize for patients is, number one, if they're feeling unwell in any way, shape, or form, you have to let your transplant providers know very quickly. That way, whatever suspicions that we may have, we can take care of it. We can diagnose it and we can take care of it very quickly. So if it's a small infection, we can treat it and it doesn't become a big infection. And then number two is to be very proactive and very compliant with the medications that you're taking 20 different medications after a transplant. And sometimes that's really hard to be able to take all of them, especially when the pills are really big. We hear that as one of the main complaints. But we make sure that people are on antiviral medications, antifungal medications. There's a medication that we use for patients to protect them for a special type of pneumonia called PJP pneumonia. And these are there in order to kind of help protect and almost substitute in a little way, because the immune system is not, number one, early on, it's not really online. And then number two, when you have graft versus host disease, it's not behaving in the way that it's supposed to. And so that's what I would highlight. There's many different types of complications, but infection really comes to the forefront of my mind.
Thank you. Dr. Holton, do you have anything you'd like to add there?
We certainly know that the graft versus host disease can affect different organs and tissues, and that the treatment can have just as many toxicities as graft versus host disease itself. I think in total, some of the most challenging issues we run into are malnutrition, just straight up difficulty eating, all the way to impaired organ function. So what Dr. Kusuri mentioned a few minutes ago is key about notifying for changes in symptoms. With chronic graft versus host disease, you want to intervene before there's permanent damage. The longer the inflammation and scar tissue goes, the more difficult it is, or it might even become impossible to reverse. And so early intervention is necessary to try to avoid that permanent damage.
That's really good to know. And I'd like to ask Meredith, for your experience here, we keep hearing about from you and from Dr. Kusuri, from Dr. Holton, that, can patients, and just like Dr. Holton said, the sooner the better. Let's let doctors know about what's going on with the body, if you're feeling something. When you talk to other patients, and just from your own patient experience, how, were you able to, did you know that you could ask or not ask, but bring these up to your doctor? Do you feel that patients you talk to know that they can do that? What do we need to do to make sure that this is happening?
One of the things that I think is important with chronic GVHD, especially, and this is very specific to myself, and so that's something to keep in mind. I was diagnosed when I was 19, so I was young. And so there are things that I have learned about over the years, and this might sound naive and kind of silly, but there are things that I learned about that I thought was completely normal that actually was GVHD. And I was like, oh, not everyone has this like weird skin thing. Oh, okay, good to know, And so I think just, and over the time that I've worked with my care team, I've developed strong relationships with each of them. And so I'm very comfortable saying like, this feels weird. I don't know about this. Can you look at like, like that, like check me out, please. And I think, and I think part of the way to be able to have that kind of conversation is really about building that relationship so that everyone is comfortable and everyone can say, or even like challenge each other and say, I'm concerned that I'm having a GVHD flare, and maybe your doctor's like, I don't know that you are. And the patient's like, well, this is what I think. This is what I researched. I'm not sure. Can we look at this? And so then you can have that kind of conversation, and you can get more out of that conversation than if there's just like a typical kind of patient-doctor exchange where it's just like, what are your symptoms? Well, this is what I've been experiencing. And oftentimes things get missed that way. And so I think for patients, really treat your doctors like people, be friends with them. you're going to be with them for a long time. And the other thing too is that like they want to know, they want to help you. And so if there's anything that seems just a little bit wacky, like ask. You know, there's no harm in asking, because it might lead to like a preventative kind of thing. It might lead to, oh, hey, that might be an infection, you know, and so it's, I think, you know, it's one of the best ways to take care of yourself is to just ask the questions.
So much more to cover now going into the treatment part of this. So Dr. Kusuri, if you could share just the current standard treatments right now for GVHD.
I think the key word to your question is current, because this is something that is changing, and we hope to continue to change as we go through the years here. But when we talk about, as Dr. Holton mentioned, there's two flavors to this. There's acute and then there's chronic. And the mainstay or the backbone of therapy for both of them is steroids or corticosteroids. So many patients and their family members will have heard of the medication called prednisone, or various types of the steroid. And so oftentimes, depending on when it's occurring, what we'll do is we'll start patients, well, let me back up. I'll say the degree of the GVHD also matters. So, you know, if you have a mild acute graft versus host disease, this is something that could be potentially managed with just topical corticosteroid, once again, steroid being the basis here. And then as it is a little bit more severe, or if it's involving more organ systems or more of the skin, we start graduating from topical steroids to systemic steroids or systemic prednisone. And that's usually the backbone here. And then depending on where we are in the transplant, our patients will already have been on another immunosuppressive agent like tacrolimus or sirolimus or cyclosporin. Those are some familiar medications for many of our patients and our family members. But the goal is to treat with steroids plus or minus this other agent, and then to taper them off once we have a response. So when we get that response, we start to taper them off and then get them off of steroids, because we all know with steroids over a long period of time, you start to, even short term actually, you can accumulate some of those side effects of steroids that we don't like to see in our patients: insomnia, jitteriness, and other ones, just fluid retention. And so those are for people that I would put into the category of steroid responsive. And then there's another category of patients where the graft versus host disease may be a little bit more sticky. And so it's either not responding to steroids, which we call steroid refractory, or there are patients who are unable to get off the steroids. So we call these patients steroid dependent, or they have steroid dependent graft versus host disease. And in those cases, what ends up happening is that we go down further immune suppression choices, right? There are other medications. One of them that's FDA approved that works in both of these diseases is called Jakafi or ruxolitinib. And then there are other various options. And so that becomes more of a longer term treatment. And so I would say, kind of summarizing it, steroid is the backbone. Depending on how severe, it could be topical versus systemic. And then the goal is to always try to get off of steroid with another agent or without another agent on board.
Dr. Holton, you know, we're going to be talking about clinical trials like in this next section. So a nice way of maybe introducing that is, what are the gaps of need, right? So what are some of the key limitations or challenges with the existing options for managing GVHD? And I know Dr. Kusuri did mention a couple of them.
Yeah, I think the greatest challenge is understanding how much therapy to give for graft versus host disease. We base our treatment based upon the severity of symptoms, but that really isn't adequate. There are still some patients that we are over-treating and some patients we are under-treating. This is where the role of biomarkers can come in. There's no blood test that can diagnose graft versus host disease right now, but we can use biomarkers to help us understand how severe is the immunologic reaction under the hood, and how much damage has been done internally that we can't detect clinically. This is a huge challenge because even though we examine patients fully and they reveal all their symptoms, we still can't really know how bad things are. So biomarkers can support us in helping to guide that therapy. This is particularly under investigation right now using biomarkers such as ST2, reg3 alpha, known as the MAGIC biomarkers, Mount Sinai Acute GVHD Consortium biomarkers, and then the one that we developed at the University of Minnesota, amphoregulin or AREG. Both of these biomarkers can be used to understand how severe is the graft versus host disease. I'd like to give an example of how I'm using this right now, even clinically. I have histories of patients that have severe infections of the GI tract. Examples could be C. difficile colitis, which I'm sure many of your listeners have heard of, or viral gastroenteritis, such as adenovirus gastroenteritis. An allo transplant recipient might have these infections and will treat the infections, but they'll have persistent severe diarrhea. And you don't know if you're still dealing with the infectious process and the healing that has to occur, or if graft versus host disease developed as a result of the immune system trying to target the infections. And even a biopsy can't always tell you this, but we can use these biomarkers, especially amphoregulin, to help sort this out.
What Dr. Holton's mentioning is, I can't emphasize how important it is, because oftentimes in transplant medicine, we're operating in the gray, and we have to make guesses. And sometimes when we're treating or approaching patients with these symptoms, it's almost like it's graft versus host disease until proven otherwise, right? And when you have that type of thought process that sometimes we have to have, it can be difficult, and we can actually hurt the patient with the GVHD management in and of itself. So it's this example that Dr. Holton's mentioning. I would say most of the transplant physicians would be like, this has to be GVHD, and we have to give them prednisone, and well, that could lead to other infections, or it can be worsening the infection that this patient already has. So we get into these situations that are difficult to manage, and if we have something like these biomarkers, it can make our lives in regards to how to correctly manage these patients with GVHD, as well as the patient's life who is experiencing this, much easier, and then with less toxicity than what we would say is the normal kind of approach.
So now we've talked about the current landscape of GVHD and treatments, some gaps of need. Before we go into the clinical trials, let's define clinical trials. It sounds very daunting. So Ashley, in the most humanized language possible, what are clinical trials?
Clinical trials are carefully controlled research studies that may be conducted by scientists, doctors, or researchers to either test new treatments or test treatments that have been used in the past in a potentially different way. Trials can also compare new treatments to existing treatments or to various combinations of treatments to find out which treatment might work best or which would be better tolerated, all with the goal of really improving care and treatment for patients.
Dr. Holton, clinical trials, big space, that's where all the research is going on for, hey, is there something better that we can be doing for patients? Can we talk about one of the trials that you helped lead? So BMT-CTN, is it 1703 trial? Can you talk about that and what the potential is? What's the excitement about that?
It's the saying that an ounce of prevention is worth a pound of cure, something like that. So the theme in these studies is really prevention of graft versus host disease. Important to state right now that our field is in the midst of a really important era. We now have very effective prevention for acute and chronic graft versus host disease with multiple modalities that we have not had in the past. The BMT-CTN 1703 study was repurposing a drug called cyclophosphamide, a chemotherapy agent, to prevent acute and chronic graft versus host disease by giving it after the transplant in the setting of reduced intensity transplants. So patients who are typically older, the median age of this trial was 66, going through transplant, would receive this chemotherapy after the transplant. And, that initially sounds kind of crazy to you. Why would you give chemo after the transplant? We're learning how this works, but it helps to deplete those alloreactive T cells. And then the good cells that we want to persist are completely immune to this cyclophosphamide chemotherapy. So regulatory T cells, which are kind of T cell peace mediators, and stem cells themselves are resistant to this chemotherapy. So what it does is it eliminates the cells we don't want and preserves the cells we do. This modality was compared against what was the standard, which was a calcineurin inhibitor plus methotrexate, and that's been the standard since 1986. So our field hasn't undergone such a major change where we did see that the new treatment arm was superior. We haven't had this kind of change since the mid-'80s.
Wow. It's incredible. I'm so glad we're doing this work, that you're helping to lead this work. And who will benefit with this?
So this is really in the reduced intensity setting, mostly going to be older adults. We did do a similar study. This was not a randomized study like the 1703 study, but in Minnesota, we did a clinical trial looking at post-transplant cyclophosphamide in the myeloablative setting. So, people might say, and I'm interested in Dr. Kosuri's input, that post-transplant cyclophosphamide is the standard in the reduced intensity setting, but not yet in the myeloablative setting. Well, we showed remarkably low rates of acute and chronic GVHD in the myeloablative setting using this platform. The rates of grade 3 to 4 acute GVHD were 5%. The rates of chronic GVHD requiring immunosuppression also about 5%. So really effective even in the myeloablative setting. Not a randomized study, not a phase 3, so we can say that we haven't done that comparison, but I have a lot of conflict of interest. I don't want to do that study because the results of the phase 2 are so good. I wonder what Dr. Kosuri thinks about that.
I agree that the post-transplant PSI has had such an impact on not only the incidence of acute and chronic GVHD, but the other thing that I've noticed is also the nature of the graft versus host disease that could develop. And what I mean by that is that even if someone were to receive post-transplant Cytoxan as a GVHD prevention strategy, or what we call T-cell depleting methods, there are other ones also. What we find when we compare it to the standard of care that we've used for very many years is that if they were to develop graft versus host disease, there is a potential that it may be more responsive to the treatment modalities that we have right now, meaning you can treat it and it can actually potentially go away, versus you try to treat it and patients may become more steroid refractory or steroid dependent. So incidence is important, and the incidence is much lower. And then I would say my opinion here is that the nature of the GVHD that may happen is also different. As far as myeloablative conditioning, if we think it works in one setting with a group of patients who may be a little bit more sensitive to the toxicities of transplant, then it is just human nature as a transplant physician that we want to try to apply it to the younger, fitter patient population who are receiving myeloablative transplants or the higher intensity transplant. And the important point there also is when we're giving higher intensity conditioning chemotherapy or radiation that is involved there, the amount of initial damage and inflammation that occurs with that approach is higher. And so the risk of developing both acute and then eventually chronic GVHD can also be higher. So if we can take this modality and we can use it in the myeloablative setting, and we can decrease the incidence of both acute and chronic GVHD, that's something that I think that we're all very supportive of.
Speaking of that higher intensity transplant group, that's also for VIC 1911, right? Dr. Holton, if you could describe what's exciting about that and who's going to benefit from that potentially.
Thank you. This is a new clinical trial that we've opened a couple of years ago now, looking to improve upon the post-transplant cyclophosphamide platform. Now that we've nearly eliminated severe acute and chronic graft versus host disease, our unmet need is addressing relapse. So we looked to see if we could do something different within that GVHD prophylaxis platform that not only keeps GVHD rates low, but also directly reduces the risk of relapse. We took away one of the drugs in the platform called MMF, or mycophenolate mofetil. We don't think that MMF probably does very much, to be honest. The heavy lifting is done by the cyclophosphamide in combination with whatever partner we have it with, tacrolimus or sirolimus. So we took the MF out and we put in a drug called VIC-1911 that's an aurora kinase A inhibitor. That drug is known in preclinical testing to keep GVHD rates low, but it also has direct anti-leukemia effects. So it helps to kill leukemia cells in the test tube and in the mice. And mice who received this combination had better survival overall due to less graft versus host disease and less relapse. So now we're testing a platform to see, does it protect people from graft versus host disease, and can it also protect from relapse? So we have two primary endpoints in this study, GVHD and relapse. And if we can move the needle with relapse, we think we'll have evolved the platform even further. So this clinical trial is ongoing right now only for myeloablative, or that high intensity conditioning regimen. But we hope to complete the study, learn the results, and if successful, expand it to other platforms.
Thank you. And I know Dr. Kosuri too, with the optimized trial, we wanted to make sure to talk about that because you talked about PT-Psi.
One of the populations in Dr. Holton's 1703 study, what we were looking at there were patients who have fully matched donors, or what we call well-matched donors. And well-matched donors could also mean having what we call a single antigen mismatch. And what we found there, and this is coming off of, using post-transplant Psi in patients who are have what we call haplodonors or half-matched donors. That's been around for a very long period of time. We've been able to successfully use that platform with very comparable and good rates of graft versus host disease reduction. So the idea is if you can use it in a half-matched or half-mismatch, you can also use it in well-matched patients. And so we call that 7 out of 8. And so what Optimize, there are two studies actually. One of Optimize is coming after another study called Access study. And the Access study is looking at the same dose of post-transplant Cytoxan that we used in haplotransplants, as well as the 1703 study, and basically reducing that dose just a little bit. So post-transplant Cytoxan is given on day 3 and day 4 after a transplant. And it's given at a certain dose, 50 milligrams each day. And so there is data in the haplo transplant setting that suggests that if we're able to maybe reduce the dose a little bit, a couple of things can happen. And this is regarding kind of along the lines of toxicity. But one of the things that interests us is how quickly someone may engraft after a transplant, meaning how quickly their white blood cells come back, how quickly their hemoglobin recovers, and also their platelets. And the idea is to test if we reduce the dose a little bit, we're still able to maintain that graft versus host disease prevention efficacy or advantage, but maybe we're able to improve a little bit in regards to the time that it takes the graft to come in. So maybe we're able to do it a little bit quicker. And that's something that this trial is looking at. It's a phase 2 study looking at patients who are 18 and older who have a 7 out of 8 donor. And it's for both reduced intensity as well as the myeloablative condition transplants.
So Ashley, we've talked about the clinical trials, but actually enrolling, even just finding them and then enrolling in them, that's a very difficult. We know clinicaltrials.gov is out there, may not be the most user-friendly, and just in general, trials can be hard to find. So can you walk us through the steps of how a patient could find a clinical trial that's right for them?
So clinicaltrials.gov is certainly an amazing resource. There is it's a database of all active and ongoing clinical trials. But just like you mentioned, it can be very challenging to use. This contains all clinical trials for all conditions. It's not exclusive to cancer clinical trials. And although cancer clinical trials do make up a large portion of the clinical trials conducted in the United States, there are just so many other clinical trials that are ongoing that it can be really, really challenging to find one that's right for you. So we, of course, as a representative of LLS and the Clinical Trial Support Center, we always encourage people to reach out. What we can do at the Clinical Trial Support Center is really hone in on those clinical trials and find the ones that are most appropriate for the individual in whatever situation they are in, as opposed to really having to filter through many of those trials on clinicaltrials.gov. We can really find a list of clinical trials that will be open for consideration for that particular patient based on their prior treatments and any ongoing conditions they may have.
If we could ask Dr. Holton, what specific nutritional and exercise interventions are being investigated to support specifically muscle health during and after transplant?
This is a substantial topic, and I always tell my patients that if I could give a pill that could keep their muscles strong, be the richest woman in the world, having the ability to maintain muscle mass throughout chemotherapy of any kind is really important, and we need to do more in this area, not just for transplant, but for all cancer therapy. Multiple studies going on around the world looking at different types of nutritional supplements to try to maintain muscle mass. Nutritional supplements that can actually help promote intestinal healing. There's some interesting research going on out of Italy using a nutritional supplement that has a growth factor that can help the gut heal itself. There might be different nutritional approaches based upon infection profiles. For example, we might want to avoid a certain type of bacteria to grow in the intestinal tract, and maybe avoiding something in the diet might help prevent that from growing. So those types of studies I think are really important, and we need to be able to expand them so more patients can participate, because in reality, we don't know what the best diet really is. Just we want people to get calories and protein in. And then the same thing goes for exercise. We need to do more to facilitate exercise, especially resistance training. A lot of emerging data suggesting that preservation of muscle mass actually helps reduce the relapse risk, right? So this is not just cosmetic. It is about quality of life, but it's also about the efficacy of the therapy itself. So lots of work we need to keep doing in this space. So stay tuned. And, obviously, I think this is the most important thing that we can work on besides improving the toxicities of the treatment itself. But supportive care is just so important. We have a lot more work to do.
Dr. Holton, you did mention that only a fraction of potential transplant candidates even get referred. So let's even rewind back to when we're talking about success here. What is contributing to this underutilization? How can we address those barriers?
I think we have an educational gap. The transplant field is vastly different in 2024 than it was even in 2021, and certainly way different than the 80s or 90s, right? So we have to do a better job of communicating what have been the advancements in care. How have we improved upon the availability of donors? We no longer need a perfect match. How have we reduced graft versus host disease and improved other toxicities so that more patients are able to be reached? I think there's a lack of referral and also a fear from the patient side as well. And I think we have a lot of education to do to share that really it is a different field today, much safer. And hopefully we can be able to take care of a lot more patients in the future.
I totally agree. I echo that. I think many of the old thoughts that we have about transplant, or the historic thoughts that we have about transplant, that you have to be, under a certain age, or, how scary it is, and things of that nature. I think many, and it's really on us to educate both referring providers as well as patients to understand that things have improved over time, both from a access standpoint, as well as supportive care standpoint. So the supportive care has really, really changed over the last decade significantly. And that's why we're able to take patients who maybe previously the field would not consider, even if they were in good shape. And the thing that I emphasize to patients is it's not just numerical age, it's physiologic age, right? So there can be a patient that comes into our clinic who is 50 some odd years old, but has been really beaten up because of the disease or the treatment. And that transplant would be very difficult for them. Whereas we can have a 70-year-old who is running a half marathon, right? So it's not just the age, it's the physiology of what the patient's body is at the time that we're considering transplant.
Thank you so much. The last thing would be final takeaway. Again, clinical trials, it's great, it's amazing, but it's daunting as a term. So one thing, if you could leave with our audience that you hope they walk away from this program with, what would that be?
I would just say that there is support available. There are resources available to help, and it's really never too early or too late to explore clinical trials when you're talking about GVHD and clinical trial options during the transplant process.
So for me, from the time that I have started, I would say over the last decade, I have more hope as a clinician in the field of transplant. As Dr. Holton had mentioned, and even Meredith had mentioned earlier, the field, even though it was trying to move, it's kind of been set in its ways for a very long period of time. But now within the last 5 to 7 years, we're seeing so much change because of our understanding of the biology of the diseases that we're dealing with coming into transplant, the technical aspects of the transplant, and of course what we were focusing on here, which was GVHD prevention, like the 1703 study, the initial treatment of graft versus host disease, how to get patients off of steroids quicker. There are many trials looking at that. And then the other thing is in chronic graft versus host disease, that is far off, kind of more severe and more fibrotic, ways to manage that. And then the other, I just want to touch upon and emphasize what Dr. Holton's work from before, regarding biomarkers. For a long period of time, kind of taking the approach of we try something, it fails, we try something else, another agent, more immune suppression when it comes to GVHD. But we're hoping to kind of minimize that approach where you kind of throw something at a wall and see what sticks, and it may be different for each patient, to kind of tailor. Number one, do we need GVHD treatment in some patients that have certain symptoms? And if it is graft versus host disease, how do we know when to come off of therapy, how to add therapy, etc.? And that's where the biomarker story becomes very, very important. So in a short period of time, major drastic changes, and I have more hope in the field for patients now more than ever looking forward.
I agree with everything that Dr. Kosuri just said, and I will add my piece that I want patients and their families to know that they have a lot of control in these processes. I believe very much in the principle of self-efficacy. Yes, this is a medical treatment that we are delivering, but there's a lot a person can do for themselves and that their family can do together to help make the process easier. I can't emphasize enough that nutrition, exercise, and sleep are key. And those pieces are really going to help recovery and resilience. And so I just want people to know that they have more control than they think, and look to ways that they can help build up their strength and resilience. Lean on their network and use these tools and resources to help build up the spirit and body to be able to withstand the trials and tribulations that certainly lie ahead. So the medical advancements are real, but people also have a lot of control, and they should know that.
I agree with what Dr. Kosuri and Dr. Holton have said. I think hope is incredibly important. I think recognition that you do have control is imperative. And I think the other things, there are a couple things. One, selfish is not a bad word. Be selfish and, put yourself first. Don't try to take care of all the people around you, because, then you're going to do a detriment to yourself. And so be selfish. If you don't want to do something, if you can't meet with somebody, don't do it. And then the other thing that I think is really important, especially when we're looking at the chronicity of chronic graft versus host disease, and that it's long term, is continuing to find meaningful and fulfilling activities so that identity doesn't become the illness. So that you are a person who does all these things and has this wonderful life, and you have an illness, but it's not defined by that illness. I think that's one of the biggest takeaways that I hope that patients and their families are able to use.
Wow, thank you all so much. These are such powerful messages, and I'm going to rewind and play it back. What I'm hearing is there's hope, there's power to be in control or have this sort of self-control, to be selfish or self-focused, whatever resonates with you more, and also to keep your identity, because we know we are so much more than any diagnosis or disease. So again, thank you so much to Dr. Kasuri from University of Chicago, Dr. Holton from Roswell Park, to Meredith with the Meredith Cowden Foundation and the GVHD Alliance, and Ashley with the LLS's Clinical Trial Support Center. The LLS being a partner of ours on this program, it really is such a great resource, this CTSC. If you're looking for one-on-one support in terms of understanding trials, finding, enrolling, and even staying on them, a great resource. And we're going to drop the information here as well as in a follow-up email. And I want to thank each and every one of you for joining us. Thank you for the time. We really hope that this was empowering, that you're able to take away not just from this program, but from the many stories that we have on YouTube. That's The Patient Story on YouTube, or on thepatientstory.com. For now, don't forget that when this closes, a survey will pop up. It'll just take a couple of minutes to fill out, and it is so important for us to understand how we can do better, what we've gotten right, but more importantly, what you want to know more of, what would be more helpful for you. So for now, I'm Stephanie Trong with The Patient Story. I hope you had a great time with us. Hope to see you on a future program. Take good care.